collapsing their small airways when they exhale. Remember that inspiration, bronchi dilate slightly, and expiration is the passive state. But what happens in an emphysema individual, they've destroyed the elastic tissue in their bronchi. And so they open, but when they exhale, they collapse. So what it ends up doing is it traps the air in the asinus, basically. And it's just like blowing up on a balloon. You know, you blow on a balloon, blow on it, you can actually, then you start getting bigger, and that's what happens to the asini. They start inflating and getting bigger. So when you do that through the whole entire lung, the lung gets bigger. But if you look at the ratio of air to soft tissue, you end up with even more air than normal, same amount of soft tissue, so the lung gets larger and more radiolucent. That's what's happening in this individual. See how big the retrosternal clear space is? And the retrocardiac space? And those are just the result of the lungs getting bigger, and it's got to get bigger at the expense of two things, the chest wall and the diaphragm. And so it's going to push the diaphragm down, and it's going to push the rib cage out. That's where the barrel chest comes from, you talk about in pathology. So we get hyperlucency bilaterally, and eventually it'll push the diaphragm down so far that they can actually end up with blunted angles, because the diaphragm just can end up being pushed all the way down like this. This is kind of a mild emphysema. That's a little granuloma 7A. But this is an emphysematous patient, but you see how the vasculature even looks more prominent? That's kind of an oxymoron with emphysema, because you think, well, if the asini are getting larger, getting bigger, it should compress the vasculature, which it does, which is why they get arterial hypertension. But because these are not real healthy people, they have recurrent pneumonias, which can actually sometimes thicken the tissue a little bit, and it can actually make the vasculature markings look a little bit more prominent sometimes, which is what this patient is doing. That one over there, you see they've got hyperlucent areas here, and there's no what in here?
Vasculature.
Yeah, here you got blood vessels, here you got no blood vessels. Well, what's actually happened over here is those asini that are getting bigger and bigger and bigger, what happens when you blow on a balloon to the point that the pressure in the balloon exceeds the surface tension of the balloon?
Oops.
Boom, the thing lets go. That's what alveoli do. You keep blowing them up, there's a point where you got them, the alveolar walls stretched out to the point they start tearing and rupturing. Well, what happens is you start doing that in a whole section of lung, you end up with this big cystic cavitary space with nothing in it. That's what a bullet is. These are big, huge bullae. You can see the walls going like this? These are just like big air-filled balloons inside the lung. There's nothing in there but air. So what happens to all the surface area for gaseous exchange?
It's gone.
Where you used to have millions of alveoli with alveolar walls, now you got one big cavitary cystic space because it just destroyed all the alveolar walls. That's what the thickened walls are here. That's the lung that's, as the bulla gets bigger and bigger, it just squashes the adjacent lung, pushes all the air out of it, and you end up with these big, huge cystic spaces. This is bullous emphysema, which is the worst emphysema there is. And these folks generally don't end up cyanotic. They usually still end up what they call them the pink puffers. You know, they're trouble breathing, but they're not cyanotic. But this is the worst emphysema because, you know, this patient may have basically no functioning lung tissue up here. This patient may be operating on, 45% total lung capacity.
Does this compress like all your vital organs in your heart?
No, it doesn't compress. Other than the easiest thing to push down is the diaphragm.
Yeah, but even with the diaphragm on the liver, would that?
No, I mean it may push the abdominal stuff down a little bit, but it's not going to impact that. The biggest impact it has is on their blood pressure, their pulmonary blood pressure, because all of these expanding spaces are squashing the capillaries. It's like standing with your foot on the garden hose. And so the pressure from out here is reflected all back into the pulmonary arterial circulation, and they get major pulmonary arterial hypertension, which greatly overworks the right ventricle. And that's what typically leads to the demise of an emphysematous patient, is right ventricular failure, the cardiac arrest from right ventricular failure. Tremendous overload on the right ventricular circulation, because now the right ventricle's struggling trying to push the blood through all of this compressed capillary beds out in the lung.
So that falls under cor pulmonale?
Cor pulmonale. The two major cor pulmonale diseases are emphysema and pulmonary fibrosis. They do it for different reasons, but they majorly increase the pulmonary arterial blood pressure. Major. And you can see they're starting to get a bit of a prominent pulmonary artery. Remember, aortic knob, pulmonary artery, left heart wall. The heart tends to get narrower and vertical, although they will have eventually right ventricular enlargement. But just like that one over there, the heart kind of gets a little narrower because as the diaphragm goes down, the heart's going with the diaphragm. Yeah. This one here, you see this wispy stuff down here? Mm-hmm. That's actually scar. This would be reticular non-honeycomb scar, is what this is. And it's in the basal area. See the prominent pulmonary artery again? Because the scar is impacting the blood pressure. Even though the rest of the lung looks normal, the lower half of the lung is scarred. This is basilar fibrosis. In a male, emphysema or asbestos would be the first thing we think of in a male. In a female with basilar fibrosis, the rheumatoids are the one that come up to the top. Rheumatoid, lupus, scleroderma is a major one that causes basilar fibrosis. So this actually was a rheumatoid patient with basilar scarring in the lung. Emphysema in a patient, and you see the hilar areas are bigger, pulmonary arteries prominent because they're getting arterial hypertension. Yeah. Pulmonary arterial.